All right, so let's begin. Yeah. So let's have a look at the scenario, reactive arthritis. So what might be the case here? So the patient started like it's around 30-year-old male came to you, and the beginning of the station was patient is like, I'm embarrassed to talk. I am embarrassed to talk. And the thing is that it will take a bit of time to make this patient comfortable. I mean, what exactly you mean? I'm here to help you. Whatever we are discussing, it is confidential. So you need to just give that safe and environment to this patient. You have to build that rapport, right? And then this patient will start talking to you, and then he'll say that I'm having a discharge coming from penis. That's the main presenting complaint. Right. So what you'll do, you'll elaborate it, what kind of color, and if it is smelly, if it is painful, all those questions you'll ask. You'll ask questions for UTI as well, right? And then obviously what you always do is you go for open questions, anything else. So after elaboration of this patient said, I have got joint pain as well. If you do not go for open question and you keep on just thinking it is STI and close it as STI, then it may not make much sense. And that's what actually a lot of doctors might be doing, isn't it? So what you should be doing, always go for the open question. So we know in reactive arthritis, what exactly we have. It is can't see, can't pee, can't climb a tree, right? So you have to have problem in the joints. You have to have like say UTI or I mean problem urethritis, and then eye conjunctivitis, right? So patient has got urine related problem, then patient has got joint pain when you ask the open question. So then what you're gonna do, you'll ask anything else. Now this patient is gonna give you eye findings or not. Most probably not. He's not gonna give you, right? So what you will be doing, you'll be ruling out other differentials as well. As patient gave you the history of discharge. So what you will be doing, you have to take a proper detailed sexual history as well, right? And then in the end, the later part, I would like to examine you. I would like to do the investigations as well. So which examination? General physical vitals, private area examination, joint examination, and eye examination. So that is what you have to mention, right? So that's the main thing that you have to do. And the treatment, you know that accordingly you can go about it. The painkiller, and if patient has got this STI. So you'll be doing the STI screening for chlamydia, gonorrhea. You treat the patient accordingly. You may have to treat the partner as well. And if it is STI that comes positive, so you may be offering HIV test to this patient as well. So that is gonna be your management. Okay. Another one, the patient actually is 50, 55 years of age, and for well-man checkup. Examination, there was a mannequin as well. So what was this scenario? So sometime what happened is that the scenario will say patient went for well-man checkup. So in well-man checkup, what we do routine blood investigations and all. And if it is a male patient, for example, and age more than 50 years, we go for PSA test as well. We go for PSA test as well. Okay. So what happened is in this age, they gave you the PSA, for example, they gave you it is 20. Now tell me what's happening. So the PSA was given, it is high, it is 20. So what it could be, right? So the thing is, they will always be giving you the normal values as well, because the normal value of PSA depends on the age of the patient, right? So for example, if for a young patient, the level of PSA is going to be a bit less, but then if it is more than 50, 55, the normal value could be around 3 to 4. But if it is 20, it is kind of a significantly high. That's what we will say, right? See, before you do PSA, we have to be very careful about few things. Before doing a PSA, you have to be very careful that man should not have urinary tract infection. That's one. They should not have ejaculated in the last 48 hours. And what else? They should not have done any vigorous exercise, I would say, in the last 48 hours. Number 4, they should not have had a prostate biopsy in the last 6 weeks. And the last one would be patient should not have had digital rectal examination in the last 7 days. Because if any of these things were there and then you do check this blood test, PSA, what's going to happen? It's going to be high, right? So it can be falsely high as well. However, if it is 20, it is significantly high, guys. So what you have to do, you may be doing further investigations as well. So usually the further investigation that you do is what we say is biopsy, right? But nowadays, before we go for biopsy, we do MRI scan as well. Based on the report of MRI scan, we will get a bit of idea whether it's a high risk case or low risk case. So based on the MRI report, you will be able to decide if you are going to go for biopsy or not. So that's the scenario, right? So patient age 50-55, well-man checkup, and the PSA test was high. It was 20. So what you're supposed to do? So you're going to take history for UTI, for BPH, for cancer as well. You may not have those things positive. So what you will do, you will do the examination. So see what it is, if it is normal or if it is BPH. Right, and then what's going to happen next? Because it's too high, so we have to go for further investigations. All right. Then there was a scenario, it's a new scenario. So how this scenario came? So there were two friends, they went to a GP. So one of them was registered with the GP, another one was not registered with this GP, he was registered with somebody else. But as like, okay, so they went together, right? So they went together to the GP, and what happened is the person who was not registered with that GP, he collapsed in the GP surgery itself, and he lost his consciousness for a couple of minutes as well, right? And now you are supposed to talk to that person, right? So how are you gonna do that? So whenever you get a station on fit, fall, loss of consciousness, vertigo, and dizziness, so what you are supposed to do in those scenarios? So you have to take history in three parts. You have to take history in three parts. Those parts are gonna be before, during, and after, right? So this is how you will take history: before, during, and after. So first you'll start for during. So patient had a fall, right? So you need to ask what exactly happened. Now I will give you a clincher. So if the patient was having dizziness, so ask the patient, what do you mean by this dizziness? If the patient says it's a spinning of the room, that's true vertigo. But if it is postural hypotension, patient will not have this spinning of the room. What this patient will have? This patient will say, I feel light-headed. Now, so it's a mnemonic for you. Lightheadedness is equal to postural hypotension. All right. So what you're going to do is, if it is fall, if it is vertigo or dizziness, ask, what do you mean by this dizziness? Is it spinning of the room, or if it is lightheadedness? Doctor, it's lightheadedness. Any jerky movements, or if there is any loss of consciousness? If there was loss of consciousness, for how long it was there? So that's what you have to do. Then you go for after questions, what you're going to ask. So after this lightheadedness episode, how were you feeling? Whether you were sleepy, you were drowsy, you were confused, do you remember what exactly happened before? Amnesia, you're going to check. Any nausea, vomiting, any trauma. So those are the questions you're going to ask. And then you'll ask for before. So in before, you're trying to get the diagnosis. What can be the diagnosis, right? You ask for fever, flu-like symptoms, any trauma before the event, any cough, for example. So you'll try to rule out other differentials as well. So what we got in this station, this patient is a known case of high blood pressure. This patient is a known case of high blood pressure, and he is taking amlodipine regularly. But what happened is enalapril was added in his medication last week. This patient is not registered with this GP surgery, registered with somebody else. And what happened is he's a known case of blood pressure and he's taking amlodipine. But last week, what happened? Enalapril was added in his medication. So what you have to do when you got lightheadedness, you got everything. So when you do the examination, I would like to do general physical examination. I would like to do vitals. And in vitals, I would like to do the blood pressure in standing and lying down position. So they will give you two blood pressure, standing and lying down, and you will be able to make the diagnosis of postural hypotension. It doesn't mean the doctor gave you the wrong medication. What does it mean? It can happen. It is one of the side effects that can happen. So it is postural hypotension. All right. Then there was an upper respiratory tract infection. It's a mother is talking about her daughter on the telephone. It's a teleconsultation. So mother is like, my daughter has got cough for last 2 days. The last 2 days, the cough is there. And the thing is a teleconsultation. So what you need to do for the cough, you need to ask all the question, what is this cough like? Right? If it is productive, if it is not productive. And with the cough, if there is any shortness of breath and what kind of phlegm it is. And if the child is okay, I mean, fever is there or not, if they're able to eat or drink properly or not, and any fever if you have got in the scenario of pediatrics, what you need to do, you need to ask for other things for fever like meningitis and UTI and constipation, for example. So ask those questions as well. And it is a demanding mother, and she is demanding antibiotics, right? She is demanding antibiotics, and she's not willing to bring the child to the clinic. So what you need to do is you need to tell her to bring the child to the clinic so that you can manage and treat the child accordingly. Okay. Then there was a straightforward scenario on celiac disease counseling. It was written in the question, the patient is a diagnosed case of it, and the transglutaminase antibodies are positive as well. And it was advised to that patient is going to go for endoscopy and duodenal biopsy. So it's kind of a more of a counseling station. Colleague Facebook, so I think that was straightforward as well, colleague consultations. Then anticoagulant prescription was there. So in this, dalteparin was also already written. So what you can do, you have to check if the patient is breastfeeding or not. If yes, so you might be going for enoxaparin in that case. And don't worry, the dosage according to the weight of the patient were written, so you can go accordingly. Right. Another station on leukemia. So this patient actually came for well-man checkup. The patient came for well-man checkup. In the question, what they might be giving you, that the WBC count is 40,000. WBC count is 40,000. So he came for well-man checkup. The reason for well-man checkup is the wife was concerned, and that's why she asked me to come for this checkup. Wife is a diagnosed case of diabetes. Wife is a diagnosed case of diabetes, and she was feeling a bit tired. That's why she went for the checkup. She was diagnosed with diabetes. And for me, what happened, doctor, I am a golf player. I'm a golf player. I used to play 5, 6 rounds. But now if I play even maybe 2 rounds, I start feeling a bit tired. And that's the reason I came for well-man checkup. If I do ice, I'm concerned about if I might be having diabetes, right? But the thing is, you have got WBC 40,000, you understand what it is. It's leukemia, isn't it? So I would like you to ask all cancer questions as well. That would be main thing. And later on when you do, I would like to do general physical examination, vitals, and abdominal examination. There is splenomegaly. Then you will disclose it to the patient. You will do proper ice. And when you did ice, patient is worried about diabetes. So you will explain it to the patient that when we examined you, what we found, there is a organ in your body, spleen, that's enlarged, and the count of white blood cells, it's usually 4 to 10,000, but in your case, it's 40,000, it's very, very high. So what does it mean? It explains we are suspecting it might be leukemia, it might be cancer. So that's the thing, right? So again, 2 weeks urgent referral, and the patient will be managed by MDT accordingly, right? Then there is a case, patient is having motor neuron disease, and patient is demanding riluzole. Patient is demanding riluzole, right? So the riluzole medicine, and this patient is going to the specialist every every 3 months. Yes, every 3 months he's going for the follow-up for the motor neuron disease. So what you need to do is you have to ask question for motor neuron disease if he's doing okay or not. He's not on riluzole, but he wants riluzole. The thing is, this medicine is always and always prescribed by the specialist. Now the thing is, when this patient comes the first time, you don't know what riluzole is. So you're like, how I'm going to manage this scenario? The thing is, the BNF is there. Open the BNF and check it out. What this medication is. So Riluzole is given, but it's not given to every patient. We have to see the benefits and risk, and then accordingly we will give. So Riluzole is meant to increase the lifespan of the patient, those who are diagnosed with motor neuron disease. But it cannot be given to everyone because it's not good for your liver. It's not good for your lungs as well. For lungs, it can cause pulmonary fibrosis as well. So you have to be very careful. But this patient has come to you in the GP. So what would be your advice? That first of all, it's given by the specialist. So we're going to refer you. And you know, you're always going every 3 months to the specialist. Why you didn't ask your specialist last time? Doctor, I didn't know that time that if this kind of medications exists. Now I got to know only. All right, so what we're gonna do is you're gonna go to your specialist, but I can expedite maybe this process and maybe we can book the appointment a bit early. Then go and check it out. Let's see what happens, right? But for you, tell that this medication has got the side effects as well. It can affect your liver, your kidney, and mainly your lungs. So what we will be doing in case if a specialist wants to start you, so they might be doing some blood test, maybe a chest x-ray, and then only they'll be able to start you on this medication. All right. Then another one, nasal polyp, 30-year-old male having a clear discharge, rhinitis, not getting better. He's taking antihistaminics, right? And there is no allergy. Somebody said it looked like a deviated nasal septum furuncle, but that was not the case. It was a nasal polyp. And this patient has got a history of hay fever as well. Now, when you get these kind of scenario, what I would like you to do is you have to rule out the red flags. I would like you to rule out nasopharyngeal carcinoma. So what you need to do is you need to ask again loss of weight, loss of appetite. What else we can ask? We can ask about if there is any lymphadenopathy this patient has got, if there is any hearing problem this patient has got, if it feels like a mass on the face. So all those questions you can ask. But if it is nasal polyp, the treatment is you might be first of all antihistaminics, or you might be giving a course of like nasal steroids as well, or if needed, maybe like another like normal systemic steroids as well. But that's rarely, I mean, that's given. But make sure you rule out nasopharyngeal carcinoma. Semen was sepsis, so saturation was okay, but then blood pressure was low, fever was there, patient is I can't breathe, I'm feeling unwell. So I think the sepsis gut is easily manageable, right? Then there is a 54-year-old female. The DEXA scan was done and she was diagnosed with osteoporosis. 54, that is understandable, right? Maybe you can take a bit of history as well to see if she's taking a proper diet or not, if she's smoking or not, or if there is anything like, say, steroid, if she's taking for anything, because all these are the risk factors for osteoporosis, right? But the station is about doing counseling for alendronate, bisphosphonate counseling scenario. So how to take bisphosphonates, what are the side effects of it? That's something that you need to explain. So tell the patient you have to take it in the morning, empty stomach, and make sure you don't lie down for at least 30 minutes. At least 30 minutes, because it can cause esophagitis, that's the thing. And it can cause jaw necrosis as well. So if you're going to your dentist, make sure you let them know that, yes, you are taking bisphosphonates. That is it. All right. Then attention headache. So sometimes you'll see this scenario might be coming with mannequin, sometimes it's coming without mannequin. So this is something we have to see. Right, so tension headache scenario. So the patient is having, stressed out, he's having pain, like band-like headache, but sometimes there's pain everywhere. And sometimes complaining about the neck stiffness as well, But the clincher that you will have would be, it is there when I'm it's usually there at work in the evening time. That's the main history you will get. So sometimes it might be coming with the mannequin, fundoscopy mannequin as well. So make sure you prepare the patient well. How will you prepare the patient? Make sure you have ruled out acute angle closure glaucoma. Then you will be having dark room. That's the most important thing. And you have to talk about putting the eye drops as well. So patient is going to see blurry. Make sure you don't drive, don't sign any legal documents, don't operate on any heavy machinery. So you will prepare the patient for fundoscopy. And then when you do fundoscopy, what's going to happen? You will have a normal fundus. You will have a normal fundus, right? Management for tension headache is simple. It's simply get the relief from this tension, stress relieving, no smoking, no alcohol, good diet, and be physically active as well, right? The patient was demanding a CT scan as well, so say no to CT. Make sure you rule out all the red flag sign for sure, right? Then there was a station patient was having a red tender nodules actually on the shin, right? So it was on both the sides, both the legs, right? So it was a straightforward erythema nodosum scenario that we have got. Then ductal carcinoma in situ, that was a breaking bad news scenario. So that is also straightforward. You need to follow Spike's protocol, right? Then sleeping problem, 45-year-old male, and drinking alcohol as well. Sleeping problem was for last 2 months, and patient was divorced 2 months ago, and mood was a bit low, but there was no suicidal thoughts, right? So for depression, to make the diagnosis of depression, you should have a history of at least more than 2 weeks. Yeah. And the main symptoms of depression, core symptoms would be low mood and anhedonia. And then you need to ask other questions as well, like how's your sleep, your eating, are you able to concentrate, what's your work like, and the suicidal thoughts. All those questions you're going to ask, because suicidal thoughts or hallucination, definitely the examiner is looking for these red flag questions. All right. So yeah, and the depression, mild, moderate depression, the treatment is CBT, 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 and CBT. And the patient was demanding actually antidepressants. Are you going to antidepressants? Are you going to give antidepressants? Not really. So firstly, you have to go for CBT therapy only, right? Have a look here. So the station was there on the performance anxiety. So it's the first time, it's a young guy, 19-year-old, again, very, very embarrassed to talk. Very, very embarrassed to talk. You have to tell them it's a safe environment. I'm here to help. Tell me. So then he's saying, I was in a bar. A girl was there. She flirted with me and she asked me to come to her room. And I went into her room. We were about to initiate the sexual activity, sexual intercourse. What happened is she commented on my penis size, that's too small. And then I was not able to continue. I was not able to perform the sexual intercourse. So that was the main thing. So the scenario is you have to see if there is anything related to erectile dysfunction, but there's nothing like that. What exactly has happened? It's only and only because of stress only, right? You ask if the patient has got any previous medical condition like diabetes or cholesterol problem, high blood pressure, nothing is there, right? Any family history of anything, nothing is there. And when you ask if he's having this kind of problem before, he's like, this is the first time I was about to do any relation, I mean. But if he's saying, if you ask about the morning erection, that's there. Nothing else seems to be the problem. He's like, I never had any problem and never had like this loss of libido, no problem at all, right? So everything seems to be okay, but then he was not able to perform the performance anxiety. He was not able to perform the sexual intercourse. That's the thing. So it's about the management is just again reassurance, talking therapy, and tell the patient, I mean, if he is smoking or drinking alcohol, so make sure you have control on those things as well. All right. There was a eye station blepharitis. That was a straightforward scenario. There was a cradle cap scenario. The mother was very concerned that my child is having some yellowish rash on the head. So cradle cap is something normal. There is nothing to worry. But then you can ask if it is only in the head or anywhere in the body or in the genital areas when you're changing the nappy, if you have noticed that or not. So, and ask if there is a sign of infection, any redness, any bleeding, any ulceration. So answer should be no, no, no. Then there is nothing to worry. It's gonna go on its own. So maybe mild shampoo. These are the things you can use, but don't try to pluck those cradle cap. I mean, they'll show you a picture as well. Normal, no problem at all, right? Then there was a scenario on PAD. Right, so peripheral arterial disease, right? So patient has got pain in the leg, so it's going to be intermittent claudication. So the thing is, whenever you get a station on PAD, you have to ask for 6 Ps. That's your pallor, right? So it is your pain, pallor, what else? Polyothermia, paralysis. Yeah. So you have to go for those 6 Ps. Yeah. Paresthesia. So, right. So now how to differentiate between PAD and acute limb ischemia? right? So acute limb ischemia, usually patient is going to present with severe pain. Patient is going to present with severe pain. That's the main thing. PAD is intermittent pain. That's the thing. There is an index that you can find, ABPI. It's ankle brachial pressure index. Ankle brachial pressure index. We usually check for the pressure in the ankle and brachial. So what do you think the pressure should be? The blood pressure should be normal, same, I mean, both the sides, isn't it? So they say the range is, if it is 0.9 to 1.2, ankle brachial pressure index, it is normal. If it is something from zero point 0.5 to zero point 0.9, it could be a case of peripheral artery disease. But if it is very much compromised, then it is a case of acute limb ischemia. Acute limb ischemia, what's the treatment? You have to go for vascular surgeon and maybe surgical option, right? Huntington disease. A lady is coming, she's around 30 years. She's worried that I might get this Huntington's. Why she's worried? Because her mother was diagnosed. Now, see, every person, first of all, so okay, if it is there in the mother, can it happen in the children? So as it is autosomal dominant, so the chances are there 50% that you can have. But the age your mother got Huntington's, it's not gonna be like same for you as well. It might be different for you, isn't it? So what you need to do is you need to ask which symptom your mother has. Then you ask questions about Huntington, symptoms of Huntington's to this patient as well, and then do the counseling. Ask if there is any other sibling that you have got, and ask if she has got any kids or if she's planning to have kids or not. And then maybe you can check this patient, you can send this patient for genetic counseling as well. But what we need to know is it's an autosomal dominant. 50% chances are there that you might get it. And you might be having a pen and paper as well, so make sure you fill it. I mean, you just draw on the paper as well, right? So that would be easy, right? Then there was a station on chronic bronchitis. The semen was stable and they were expecting us to fill the news chart, right? That's a straightforward. Then there was a station on BLS. It was clearly mentioned that do not demonstrate, do not demonstrate the rescue breath. You just have to explain the rescue breath thing, but you don't have to demonstrate the rescue breath. OCD, very much it's coming all the time. OCD, the patient is saying, I mean, sometimes he's just checking the locks 5-10 times before going out. Another thing is saying, I've got a ritual of 1 hour. I mean, and also he is just tapping on the table. Like before I start eating, I have to tap at least 5 times, then only I can eat. And during the conversation with you, we'll be tapping on the table again and again, again and again, again and again, right? So obsession is there, and that's why it's a compulsive behavior, obsession compulsive disorder. So the treatment is CBT. Make sure ask about the mood, anhedonia, again, depression you will rule out, suicide and all you will rule out, and that should be okay. Folliculitis, very easy scenario, dermatology. It's also, patient will say Brazilian wax, right? And prescription patient is prescribed lithium, and the problem is patient has got a fracture, patient is in pain, and nurse asked you to give ibuprofen. The thing is, ibuprofen better not to give with lithium. So what you need to do, you need to prescribe, you have to prescribe this paracetamol 4 times. Yeah, that's the thing. Sensory ataxia, we did discuss in the last webinar. The video is there on the YouTube, and it's a patient is having weakness or numbness in the legs, both legs actually. So you need to differentiate: is it cerebellar ataxia or if patient has got GBS? Because it feels like patient is not saying it, but it feels like it might be like ascending paralysis as well. So ask the question as well. Do you feel that this weakness is coming upwards? So that is one thing that you can ask. Another is any fever flu-like symptom. That will be a risk factor for your GBS. That's what we can ask, right? For cerebellar, you can ask for the coordination problem if this patient has got, right? Later on, what we found, this patient is actually vegan. This patient is actually vegan and taking nitrous oxide as well. How much? It is 100 canister per week. Vegan will give you vitamin B12 deficiency, and if you are taking nitrous oxide, it can make your vitamin B12 deficiency even worse as well. And examiner said patient has got Romberg positive, which means patient has got sensory ataxia. Right? So what you need to do, you need to tell the patient to stop nitrous oxide. You need to take vitamin B12 supplement as well. Check vitamin B12, check folate as well, and give injections for vitamin B12. And then maybe you have to give the tablets later on for vitamin B12. If it is not treated, it can lead to permanent damage as well, right? Subacute degeneration of the spinal cord, that can happen. Okay. Then there was a station on a surgical abortion, miscarriage, that's a normal scenario that's coming. Then there was a station on allergy, patient with allergy, like it's a EpiPen scenario, so that was a normal scenario. Then there's a scenario on counselor change. Patient wants to change the counselor. Straightforward, no problem at all. But don't forget to report. Don't forget to report the counselor. That's the main thing. Ask if the relationship is consensual, forceful, and then you go accordingly. There's a station on interception. The station starts with my child is crying, and it is intermittent cry. He cries for some time, then he's fine. He's crying for some time, then he's fine. He's crying, then it's fine. Right? And the leukemia was there as well. Right? Next. So there was a station on angry patient. Yeah. Angry patient. So it's an infected cyst, and the patient was treated with antibiotics. Now patient is absolutely fine, but the thing is, patient is angry, thinking that you made a mistake while treating my cyst. The thing is, after any surgery, what can happen? The infection can happen, which is a non-complication. It's not a medical error. Okay. The phlebotomy teaching, that's straightforward. One question you might have from the student side that if the patient is shy to needles, if the patient is not comfortable with the needles, patient is worried about the pain, just say blood sampling is just gonna feel like a sharp scratch. That's it. Okay, so that's the phlebotomy teaching. Down syndrome counseling. The lady is 46 years of age, got to know that I'm pregnant. She got to know this yesterday that I'm pregnant. She is worried because her friend, son, was recently, her friend, one of the kid was diagnosed with Downs because she was pregnant a bit later in her life. Like she was also 45. So she's worried if I'm at risk of getting Down child. Then you need to tell her about the screening program that we have got. So what we do is number one is the combined test we do. That's the main thing, right? So in combined test, we do an ultrasound for knuckle translucency, and then you do a blood test as well, right? So there are two blood tests. The one is Papa A and then Inhibin. So those are the two blood tests we do. There's a quadruple test as well, but that's done if somehow we were not able to do this combined test, right? So these are the main things. Another thing is if, for example, if the risk of when you did the combined test and the risk was very high, say 1 in 150 is the risk of having a child with Downs, then you might be going for some further investigations as well. So there's a test that you do. I just forgot the name. Let me have a look. So in that case, you might be able to do that test as well. And that is actually, before we go for diagnostic tests, so the diagnostic tests that we have got is, just a sec. Yes, so the diagnostic test that we do is amniocentesis and chorionic villus sampling. But before that, there is a test, NIPT test. That's also a blood test that can be done. It has got higher sensitivity. So remember one thing, it's not the first priority. It is done later only. first test that we do is a combined test only, which is an ultrasound to check for knuckle translucency, and then this beta HCG and Papa A, beta HCG and Papa A. So these are the blood tests. That's what we do. Then in the quadruple test, we have got something that we say is inhibin and other hormones we will be checking, but that's only done if somehow because of any reason the combined test was not done. So okay, let's make it easy. What do you need to remember? First test you do is a combined test. If the risk of having down child is high, it's 1 in 150, then usually we go for NIPT where the sensitivity is very high. Usually we don't go for NIPT as the first thing, right? If the patient wants to go in the private setup, that's absolutely okay. And it costs around 3 to 500 pounds. However, if the patient is high risk case, if the patient is a high risk case, can we say our patient is high risk case? She is 46. So definitely it's a high risk patient. So what we can do in that case, maybe we can offer combined test and maybe NIPT as well. So that's what they want to see. Yep. Another, it's a patient wants to quit heroin. That's the thing. And when you ask why you want to quit heroin and all, so it's like, I want to quit. My wife also wants to quit. And this patient is a bankrupt and he has been arrested a few times with for shoplifting as well. And he tried quitting heroin last time as well, but he was not able to quit because of withdrawal symptoms. So what you have to do is you have to take proper history. I mean, cage, DWT history you need to take, and then ask MISH-FAM, like the mood of the patient. Insight is always there. Suicide, you can ask if the patient has got hallucination or not. And then the friends, family, you need to ask. As you see in this case, patient wants to quit smoking and my girlfriend is a drug abuser as well. So please check out if we have got any child also at home or not. Because if both the parents are taking drugs, the child might be at risk as well. It might be a safeguarding issue as well. So just work on that. Otherwise, patient wants to quit, insight is there, should not be difficult, right? So this was a scenario on actually neuropathy, diabetic neuropathy. So what was there? Patient was on metformin and the patient has got pain in the foot. So I would like you to do full Socrates. So let's see what is this pain like. And the patient is having diabetes for more than a decade, right? Patient is on morphine, but patient is non-compliant. That's the main thing. Patient is non-compliant and taking paracetamol for 3 months as well. Patient is taking paracetamol for 3 months as well. And examination, the examiner will tell you reduced neuropin sensation. So it's a diabetic neuropathy scenario. Okay. Then Kawasaki disease. So what you need to know is if it is Kawasaki or scarlet fever. So few things that you need to remember. It happens in less than 5-year-old kids. That's one thing. The fever is gonna be for maybe more than 5 days. That's one thing. And the patient has got usually unilateral lymphadenopathy as well. In scarlet, it's bilateral. Here, it's going to be unilateral lymphadenopathy, right? Treatment is IVIG and aspirin. Aspirin is usually not given to kids, but given in Kawasaki. That is the main thing, all right? And what you'll get, you'll have the rash and a strawberry tongue as well. Yeah. Basal cell carcinoma, patient has got a lesion on the nose. 70-year-old and patient is wearing glasses as well. Patient is saying it's increasing in size and I'm struggling to wear glasses because of this mass on my nose. Shouldn't be a problem. Bisexual boy, 16-year-old. So he's like a 16-year-old boy. He's dressed like a boy as well. He is mentioning that he has a crush on the senior boy and he has a feeling in the past, but there is no relationship. So he was having feelings for other male, other boys as well, but he has no relationship. Now he is actually having a crush on the senior. He didn't speak to anyone regarding it because he feel embarrassed. He doesn't know like how others are gonna feel about it, and then what you say is that the conversation we're having is confidential. He will ask, what do you mean by confidential? So you can explain. He knows that the senior is openly, he's a gay openly, but he is interested in him, but he has never expressed his intentions to him. His concern is what is confidentiality, you can explain, and his concern is normal to have these feelings. What I'm going through, is it something wrong or if it is right? And then you can explain that what you're feeling is that there's nothing wrong in it. It's a different way of thinking, but there's nothing wrong in it. And you'll be able to put you in contact with the organization, LGBTQ groups and all, that should be okay. Also check his mindset as well. I mean, his mood, any like suicidal thoughts, any friend circle, if he's spoken about it to the friends, family, encourage him to talk to the friends and family as well. We can put you in contact with the groups. So our counselor will be able to prepare you in a way and you will get more confidence to speak to your friends and family as well. So that is something that you can talk about. STI retained tampon, so patient is having greenish discharge and take full sexual history and all, you may not be able to find anything positive, right? And he says the husband has a vasectomy as well. But when you mention I would like to examine, you will get a finding that there is a retained tampon. Again, in the beginning, it starts like, I'm embarrassed to talk, I'm embarrassed to talk. You offer, it's a safe place, tell me. Then it's a greenish discharge. When you have greenish discharge from vagina, what comes in your mind? STI, STI, STI. Take history accordingly, ask about fever, nausea, vomiting, any ulceration or any ulcers in the genital area, any hotness in the genital area. Then ask for UTI symptoms as well, sexual history as well, and then you'll be able to get this in the examination, retained tampon, right? Then there was a rape, sexual assault scenario as well, that we were playing cards. And what happened is it's a friend's birthday party actually. So it's a cousin's birthday party and his friends were there as well. I went there and we were all playing cards. Then I went out with one of his friends and then I was physically assaulted and sexually assaulted as well. That's the thing. But now the thing is, he is coming here, he wants a sick note. That's how the station starts. He's a bit uncomfortable. I want a sick note. I want a sick note. So ask why you want a sick note. And then you ask, okay, what work you do, for how long you have not been to the work, what's the reason behind it? Are you not enjoying going to work? Is there any problem at work? So you have to see all those things, what's happening, right? And it's like, I can't concentrate at work and all. But then when you will see those non-verbal cues and you ask them, he will be able to open up and give you the history, right? But the thing is, all this incident and all, it happened a month ago. So obviously we can refer this patient to the sexual assault referral center, but they can screen the patient for STI and all, that should be okay. But then I don't think so they'll be able to take the samples and all, like semen sample or any intake and all, because the samples and all should be taken within 1 week time. But the incident this patient is saying has happened a month ago. But definitely we can refer the patient to SART and screen the patient for STI at least. Yeah. Another one, so patient was admitted because of COVID. Patient was about to be discharged. It's an elderly lady and she was about to be discharged. While going to the bathroom, what happened? She fell down because of the slippery floor. And the hip examination findings were given to us. It says left leg is shorter than the right one and it is twisted as well. Patient is saying, can I go home? And now she's having pain in her hip area. That is the main thing, right? And examination findings were clearly telling us it's a fracture, right? And nurse has, after this fall, nurse has asked you to talk to her. And the pain is about 6 to 7 out of 10. So and she's 68-year-old female. So there are lots of information given to you in the questions. You know, it's more of a counseling station. So you need to involve the orthopedic team to manage this fracture further. Can I go home? Obviously not now, isn't it? She's okay in terms of COVID, but she's not okay in terms of fractured neck of femur. All right. Then there was a domestic violence, that is, the patient has got presenting complaint of sleeping. Patient is not able to sleep actually. So that's the scenario 6-7 months ago. So you know there are lots and lots of reason of insomnia. So you can ask all those things, but here the problem is I'll get some non-verbal cue, and it's the environment at home. Patient is not comfortable with the partner, right? So that's the reason, because the patient is having insomnia, right? There's a prescription for atenolol and apixaban, straightforward, but this patient was already admitted and was prescribed, patient is already on dalteparin. So you have to be very careful, but you are advised to prescribe atenolol and apixaban. So you'll prescribe atenolol, you'll prescribe apixaban, the dosage you can find from the BNF, but make sure you don't forget to cross dalteparin. Yeah. Then there was a Simban fever, patient is feeling unwell, so I think you can easily manage just to A, B, C, D, E. The main thing is patient is having fever as well, patient is having chronic bronchitis, he is on blue and brown inhaler, that's the thing, but he's not taking the inhaler regularly, that is the reason he's having this infection. All right, there's a station of intestinal obstruction, severe pain, 8 to 9, didn't pass stool for the last 1 day, and he didn't pass the wind as well, right? There is a mannequin, so he palpate, there is pain, generalized pain, overall tummy, and the bowel sounds were there as well, but they're like high-pitched, and tinkling sound was there, which is typical for intestinal obstruction. Again, if you're not able to hear much in the mannequin, don't worry, patient is not able to pass stool for last 1 day, not able to pass wind, you can say it's intestinal obstruction, right? Here, if you see the station on the medication overuse headache, yes, the patient is taking paracetamol, ibuprofen for last 6 months, now having pain. So it's a pain because of medication overuse. The treatment is you have to stop. So first of all, obviously rule out other differentials of headache as well. And what you have to do is we have to stop these medications. That's the main thing. You have to stop these medication abruptly. Of course, sometime when you stop it abruptly, it's very difficult for you to manage. If that's the case, maybe we can give naproxen PRN as well, but try not to give anything. And it's more of a counseling, that is something that you have to do, but try not to give any medication in between, right? So when you are stopping this paracetamol and ibuprofen. However, remember one thing, if your patient is on opioids, if your patient is on opioids, you might be stopping it slowly. You might be tapering it down and then stop. However, if patient is on paracetamol and ibuprofen, you stop it abruptly. That's the main thing, right? There's a straightforward case on post-op counseling, hemiarthroplasty. Patient is worried about having a clot in her leg. Easy. There's a station of alcohol-related liver disease, very old scenario. It's abdominal distension. Suspected mesothelioma. It's a case where a patient presenting complaint this time was hemoptysis. There's a father having history of lung cancer. Patient is a smoker and working in construction factory as well. You can easily manage it. Smoking, patient is about to have angioplasty, but you have to do the smoking counseling. Patient is not willing to quit. Easy one. There's asthma. That's a prescription one. Straightforward, old scenario. Chickenpox, sick note. That's the thing. So that is also the straightforward one. Very old scenario. Cervical smear counseling. That's straightforward as well. Very old scenario. Epistaxis scenario. So epistaxis scenario, the patient is having blood coming. So you need to try finding it out any cause, if there is any cause or not. For example, the patient is having any problem, any polyp, carcinoma, nasopharyngeal carcinoma, or patient has got any bleeding disorders and all. Nothing is there. And when you ask this patient when it happens, what do you usually do? And any blood, if you see, you really need to rule out anemia as well. This patient, what he's doing whenever he's having blood, he's just lying down so that the blood is going down. So it's not coming too much from this nose, but it's going in the tummy. That's what is happening. So you need to advise the patient what you're supposed to do, that you have to pinch the nose from here and you have to bend down, not like this. You don't have to lie down. You have to bend like this in front and just put some pressure here. That's the main management. But if it is there for a long time, you have to come to the hospital. Right, so that's what we do. Very clearly mentioned in the flashcards as well. Simban hematomasis, straightforward. Any spinal fracture child, it's a 4-month child having spinal fracture and living with the mother, but father is not biological father, so that's straightforward. The sensitexia, as I just discussed, it's coming every other day. Chronic hepatitis B counseling, so the hepatitis B, whether it is acute or chronic, so you can check that out as well. So results you have to disclose as a hepatitis scenario, and the results are given hepatitis B positive, so shouldn't be a problem. Quinsy medication, so prescription, that shouldn't be a problem as well. You have to give phenoxymethylpenicillin and metronidazole. Knee arthroplasty postponed due to high BMI, normal counseling scenario. All right. Okay. Now there's a station endometriosis, 26-year-old with abdominal pain, taking ibuprofen, and this is meso. Is it mifepristone or what? I'm not pretty sure about it. Right? And the pain is there with menstruation. Patient is not sexually active now, but patient was sexually active before that time. Patient was having dyspareunia as well. Now patient is having heavy periods as well. This patient actually had early menarche as well. Now, mostly we got the diagnosis, but those who didn't got the diagnosis, they did very good eyes. And what's the patient idea? Patient said, I know it is endometriosis. How patient knows? Because the GP has already told this patient that you have endometriosis, right? So the patient has come to you again in the gynae clinic because the pain was a bit worse. That's it. Yeah. And an examination, the findings are bimanual tenderness is positive. Uterus size is normal, but it is tender. So if the management is painkiller, might be able to give COCP or other medication like Mirena, GnRH analog, depending on the case, right? ADHD in 18-year-old boy, the task was the patient was referred by the student counselor. He's in a uni and referred by the student counselor to the clinic. And he was not assessed previously. And even in the conversation, it's just looking outside the cubicle, right? And if you did the psychosis questions, all negative, no hallucination, no thought disorder, no problem at all. And the symptoms of this attention deficit is affecting his work, affecting his home life as well. And he had the similar issues in the primary school as well, but he didn't bother, his family didn't bother, but now he was having the same problem in the university as well, and that's why he was referred by a student counselor to the clinic. All right, there's a bacterial infection, impetigo, straightforward. Then there's a station on lithium toxicity, no problem at all. Father has the problem. Right, so lithium toxicity. Primary enuresis. The thing in primary enuresis, this time your child was 8 to 9 years of age. Again, just to make sure it's primary enuresis, what you're supposed to do, just check if there is any constipation, if the patient has got any UTI, the patient has got any diabetes, if there was any dry period previously, or if there is daytime bedwetting or not. So just try confirming those things and all, and check the home environment and all, and then we can diagnose, say it's primary enuresis. So you can start the patient on a few things like alarm, like reward therapy. Make sure when child is going to the bed, they pass urine and then they go to bed. They don't drink enough water, in the evening time. So all those things you can mention, and hopefully it should work. And if it's not working, then what should be the case? If it's not working, then maybe we can refer the patient to the specialist as well, right? There's a station on with the DRE, a digital rectal parietal mannequin. It was acute prostatitis. The patient has got pain down there in the perineal region, actually. And the patient has got some symptoms of UTI as well, and pain in the perineal region. When you do the digital rectal examination, it's painful, but looks like more of a normal prostate. Yeah, but the patient has got multiple sexual partner and a history of unsafe, unprotected sex as well, right? So some said there was some UTI symptom, some said there was no UTI symptom, but there was pain in the perineal region, right? So we refer this patient to the gum clinic as well, and you give antibiotics. When it is UTI, you give antibiotics for a short period of time, but when you are diagnosing the patient with acute prostatitis, you might be giving it for a bit longer duration. DKA patient refusing admission. So you have got like where the presenting complaint is tiredness and all. But here the things is, in this station, the patient presenting complaint was vomiting. It's a young female vomiting. A lot of people, they thought it might be a station of pregnancy. It's a pregnancy scenario, but no, it's a vomiting. But then you ask more, patient is having tiredness as well. And then uh, you'll be able to get the findings in the examination, in the investigation as well. She is not willing to stay in the hospital. She is not willing to stay in the hospital. You need to find out the reason. What's the reason behind it? So the reason is my father has dementia and I have to look after him. So that's the thing. And I have to look after him. So that's why in the house also, in the home also, I forget to take insulin as well. So two things, you got the reason why she is having DK, she forgets to take insulin because she's spending more time in just looking after the father having dementia, right? And she's refusing the admission because she has to look after the father. So I think you can do the counseling and we can hope for help for dementia as well, right? So dementia care and all we can definitely mention. Yeah, explain that why it's important for you to stay in the hospital. The treatment is done in the hospital, can't be done outside. NI spinal fracture, straightforward. Teaching female catheterization, no problem at all. Vasectomy counseling. Another thing here, I'll tell you, what is the main clincher in this station? It's a 26-year-old male, married for 3 years, and he doesn't want to have children and decided with the partner 6 years ago. So before marrying, they were in relationship for a very long 6 years, and they decided we will not be having the kids and all. So, and they're now married for 3 years, and he is 26 and no kids and all, and they are like, I want to have vasectomy. Okay, but then what you do is you offer other contraceptive options as well. So he gave a very typical finding that my partner is taking actually COCP. But the thing is, she sometimes forgets to take it on time. So that's why I want to have vasectomy. And they don't like using barrier methods. So what we should be doing in these kind of scenarios that you need to talk a bit more on this forgets to take. I would like you to check if she has got any learning disability or not. And then you can advise her that it is better to go with COCP, or we can offer you something like, say, injection. So injection is like once in 3 months. Then you don't have to take it on the daily basis. So maybe you will be able to convince this patient or counsel this patient on this point. It's coming for a very long time, but this is something I got to know recently. So the 26, 27-year-old male, married for 3 years, want to have a vasectomy, doesn't want to have children. He doesn't have any children at the moment, but you have to refer this patient because you should not take the decision of vasectomy here, because 26, if somebody is having no kids, less than 30, it's not an easy decision to make. Yeah. So please search for this. There was hypothyroidism, and this is a straightforward one, no problem. Epistaxis is coming quite often. So bleeding from one nostril, estimated 3 teaspoons, lean back during bleed, and there is no sign of anemia. So you have to tell the patient you don't have to lean back during the bleed. It has to be forward. Yeah. Then there was a contraception, 15-year-old daughter. Mother is worried that if you have given contraceptive pills to my daughter. Straightforward. Testicular cancer, mannequin. So it's a combined station. Family history, brother has cancer, and there is history of undescended testes as well. Post-op constipation, cocodamol, straightforward. Quinsy prescription, straightforward. Yeah. Okay, ABG, straightforward. Post-MI depression, that's the thing. So this patient had MI long time back, and when you check the compliance, the patient is like, I'm not taking the medication. I'm not taking the medication. And he's like, I can't concentrate. His mood is low. He can't concentrate at his work as well. And sometimes when I forget, I can't concentrate. I feel like if I forgot taking the pills one day, I feel like I have to take 2 drugs tomorrow. So I have to take it double the dose tomorrow. So that's the problem actually. So you need to cover those things. So lack of concentration is there, mood and anhedonia, suicidal thoughts and all you need to check. and you'll manage this patient accordingly, right? So post-MI depression, CBT, cocodamol constipation, and patient has got fecal impaction, right? So adult BLS we have, scabies in the child, CT scan head injury, it's adult head injury, and the patient had vomiting 3 to 4 times after head injury. So you know it's a straight away criteria for doing a CT scan head, right? Then there is one chronic bronchitis. So news chart was there, and you were supposed to fill that news chart actually, right? You have to take history, and the patient is not very much compliant with the inhalers. Counseling for hyperthyroid straight away, preeclampsia 38 weeks, and she wanted to have pool birth. So you have to see, sometimes they give 36 weeks, sometimes they give 38 weeks. You have to be very careful. 36, what is the management? 38, what's the management? Because usually in preeclampsia, we deliver the baby after 37 weeks. So if it is 36, wait. If it is 38, induce the labor. But a big no to pool birth, right? Lithium prescription, always it comes. Suspected mesothelioma, straightforward. HIV, straightforward. The patient has got lumps in the groin area. Young patient and is bisexual, no safe sex. So generalized lymphadenopathy. Yeah. Women upset about having a girl. So this scenario used to come very long time. Now came again. So the woman has got 3 daughters. Now want to have a boy. So in the NHS, do we allow that? So first of all, you have to ask about these 3 daughters, if they are healthy enough or if they have got any genetic, sex-related genetic problem. So they're healthy, no sex-related genetic problem. Also, I would like you to ask one more thing. I mean, this is what she wants. She wants to have a boy. See who else is in the family and check it out if she's been forced for this. Maybe she has been forced by the family member or by the partner that we want to have a male child. Let's go and speak to the GP. So you need to check that thing as well. Right. And she's like, no, I'm not being forced by anybody. And she's not having any non-verbal cue. She's very confidently talking that I want a boy. Why you want a boy? Because to run the family name, you have to have a boy. So it doesn't make sense, but you have to deal with her. So talk to her and explain that your daughters are healthy, so there is no sex-related genetic problem, so we cannot help you out having a boy. Right? Ask her from where she got this information and all. Then she's asking, if I'm pregnant, will you be able to tell me the gender of my child? Yes, we can tell you the gender of your child. That's not a problem. But can I abort it if I found out it's a female? No. Abortion has got the criteria, and gender is not the criteria. So that's how you can do it. Old scenario, you can always find. Osteoporosis, it's again allogeneic counseling. And it's a patient is a female on testosterone. That's the thing. And now presenting with nosebleed and headache. So very old scenario. Then there is a medical error. There's a foreign body in the esophagus. So it's a patient has come and X-ray was done. The doctor thought it's normal. We sent the patient home. Formal report came later and it was there that there is a foreign body. Then you have to call the mother and you ask the mother to bring the child to the hospital again so we can check it out. Yeah. Then there was a teaching station for testicular, yeah, inguinoscrotal, OCD, again, COCP mom asking about the daughter, that if you give these COCP to my daughter, prescription, pneumonia, Huntington's again, post-op infection again, colonoscopy after sigmoidoscopy. So the patient had, we did a sigmoidoscopy because patient was having some bleeding for rectum and we found some polyps. And now we have planned for colonoscopy. And this patient is not able to understand that you have already done this test, why you want to do it again. So you'll be able to check, like this time we'll be able to check it as well. We'll be able to remove those polyps as well and check them accordingly. So again, it's a more of a counseling station. Then hypothyroid, straightforward. Wax infection, second visit. This is a very typical scenario. So what you're supposed to do, you have got 2 scenarios here. Patient had wax and was given sodium bicarbonate eardrops, right? Go and talk to the patient because still he is having hearing loss. So there are two scenarios here. So first scenario, second scenario. So what positive findings you'll have? Here, this patient is saying, I'm having a hearing loss. And if you ask, if you still feel you have got oral fullness, He's saying there is no oral fullness, hearing loss is there. Here, this patient is saying hearing loss, obviously it's there, but oral fullness is also there, right? So when you do the examination in both the things, oral fullness is not there. So when you check the tympanic membrane, so oral fullness not there, the tympanic membrane is clear actually. It's clear. But patient is still having hearing loss. I did hearing test. Patient has got sensory neural hearing loss. That's one. Another one, patient has got oral fullness. Patient has got hearing loss as well. So in this, when you check hearing, patient has got conductive hearing loss. And when you check for tympanic membrane, patient has got wax. So in this, what you will do, you can do the syringing and you can take it out. But here the patient has got sensory neural hearing loss. I've seen a lot of people, we are not asking and we are not doing the examination properly. And they say, I'll just take it out by doing syringing and all. But when there is no wax, what are you going to take out? And please check what kind of hearing loss patient has got. Please refer this patient for further investigation. All right, so that's what you have to do. Then aneurysms, blepharitis, again melanoma or non-melanoma skin cancer, endometriosis, dementia, patient is on palliative care, bladder cancer, so you know the risk factor, and then the morphine toxicity syndrome. All right, so that is what we have. Okay, so that's what we have here, and so PSA counseling, as I was saying, so this is what I was talking. 40 to 49, it's 2.5. 50 to 59, it's 3.5. 60 to 69, 4.5. 70 to 79, 6.5 is the normal range. But your patient, it's 20. So that's the problem. Yeah. Osteoporosis, so you should know like how you're going to manage the bisphosphonates, how to give bisphosphonates. Right, sick note, that's easy one. Intussusception, so one question from the mother side. Is it gonna subside on its own? It is unlikely it's gonna subside on its own. You have to do some interventions. Usually, we will be doing enema, right? So air barium enema will be done, right? Hypothyroidism, that's straightforward. Hyperthyroidism, straightforward. HIV, very old scenario. Emergency contraception. So there are two options. One is the pill, second is the coil. Emergency pill, you have got two pills, Levanil and where is Elawan, Elawan. And one has to be taken, this is Elawan, within 5 days. Yeah. So that was the picture they gave it to us, erythema nodosum. Yeah, rash on the leg. DKA, I said the presenting moment could be tiredness, but this time it was actually vomiting. Yeah, and the father has dementia. That's why. So please explore. When she says, I don't want to stay in the hospital, why? Right? Primary neurosis. So toilet training, avoid drinks before bedtime. That's what I said. Avoid caffeinated drinks, reward the child. See, reward the child not for, okay, if you will not wet the bed tomorrow, I'll give you a chocolate. Don't do that. Because when the child is wetting the bed, it's not in his hand, it's not in his control. So if you say this thing that I'll give you chocolate if you won't wet the bed tomorrow today, it's actually going to put extra pressure. So you should reward the child for pass urine before you go to the bed. Do not drink too much of water in the evening time. Reward the child for this thing. So be careful on that, right? Refer to the pediatrician or if the child is more than 5 years or is suspecting secondary neurosis. And in case like child is going outside, I mean, to sleep for sleepover or something, and you might be feeling embarrassed, so we can give desmopressin as well. So that's something we can mention. Lithium toxicity, tremor, difficulty walking. So you have to manage the lithium toxicity. So fluids and dialysis might be done. Impetigo, bacterial infection. ADHD, so we can give methylphenidate as well if needed. Endometriosis, Don't forget eyes. Patient has already been to GP. GP has already given the diagnosis. Yeah. Epistaxis. So yeah, you know what can be done. It's like pinch the nose, lean forward, not backward. Yeah. Cervical screening, that's straightforward. Mesothelioma. Yeah. Medication overuse, headache. Intestinal obstruction. Rape and sexual assault. So all the scenarios, I mean, you can easily find it out. Yeah. So that's it. I mean, from my side, there is nothing else I want to discuss. That's it, guys. That's it.